So good evening, everybody. So we're going to talk tonight with Frédéric Pouliot from Quebec about the present and future of prostate cancer imaging. So as Horace told you, this is the accredited presentation and session from the CUA. These are our disclosures. And so what we want to discuss tonight is the indication and limitation of the conventional imaging techniques that we use on a daily basis to stage and restage the prostate cancer in our patient from localized and metastatic disease, and to talk about the coming new imaging in advanced prostate cancer, and what are the changes and future promises in our Canadian landscape. So in the first chapter, we will discuss the role of imaging at the initial diagnosis of prostate cancer in terms of local staging, lymph node, and bone metastasis staging. The actual methods for imaging are expanding from the conventional CT scanning and MRI and bone scan to new molecular imaging modalities that we will discuss at the end. Most of them are still under investigation. However, there is still no consensus on what and when to use these methods. These are different recommendations and guidelines from scientific associations of North America and Europe, showing no clear consensus on the indications for primary staging imaging in prostate cancer patients. So basically, the Gleason score, the clinical stage, and the PSA are the main indicators in this algorithms, but only European countries put the MRI in their recommendations. So the three conventional imaging modalities, again, that we're using on a daily basis are listed here. The anatomical imaging modalities, the CT scan and MRI, and the bone scan, the technetium-99 bone scintigraphy, as you know, is detecting any bone remodeling process, so it is not specific for bone metastatic depots. So the initial staging focuses on the T staging within the prostate. The multiparametric MRI is the best tool to use for that purpose. The nodal status in the pelvis and outside the pelvis along the retroperitoneal templates drainage is usually assessed by CT scan or MRI. And finally, the bone status by bone scan. But again, CT scan and MRI are very good also imaging modalities to detect bone metastasis. The local staging is usually performed by combining the initial PSA, the DRE, digital rectal examination, and the results of the prostatic biopsies. However, the systematic 12-core biopsies are inaccurate detection of clinically significant prostate cancer that leads to underdiagnosis and undertreatment, but also an overdiagnosis of non-clinically significant prostate cancer, and that leads to overtreatment. Multiparametric MRI may be used to target the biopsy to the suspicious area within the gland on the images, and to improve the detection of clinically significant prostate cancer. A huge amount of literature right now is on this subject, and there are important ongoing studies. So the multiparametric MRI is the gold standard for prostate cancer localization within the gland and in the boundaries. So as seen in these images, the typical suspicious area within the peripheral gland on the left side on this case will present as an hyposignal and T2 weighted sequences on this image here, but also an hyposignal and the restriction of extracellular water circulation due to an abnormal number of cells in this area, hypercellularity, and that's in the diffusion weighted images, and the negative of it that we call the apparent diffusion coefficient, or ADC map. And the last sequence is a gadolinium injection, or the dynamic contrast enhanced sequence. And in this sequence, you see an early opacification, the same location, after the gadolinium injection, the dye, with an early uptake and a delayed washout, and that's due to the hypervascularity within the tumor. So that's the typical images and sequences that you can see to detect cancer depot in the prostate. However, being the best imaging modality for local staging compared to ultrasound or CT scan, MRI still has a poor sensitivity, as you see, for extraprostatic extension, 0.57, seminal vesicle invasion, and also extracapsular extension diagnosis. But globally, it has a good specificity for the all three. These results are from a meta-analysis from the Netherlands. In summary, the multiparametric MRI of the prostate using the three sequences that we discussed, the T2 weighted, the diffusion weighted, and the dynamic contrast enhanced images, is highly specific but poorly sensitive for local staging. By using an endorectal coil, may slightly improve the sensitivity for seminal vesicle invasion diagnosis, but we don't use too much this endorectal coil because it's not very nice for the patient to get this endorectal coil. Is quite large, and the extra corporal coil are quite efficient for the same purpose. 3 Tesla machine, they have a better resolution than the 1.5 Tesla, but they are more sensitive to patient movement, and they have a higher rate of artifacts on the images. Only one randomized study from Roots in 2015 looked at the potential use of a multiparametric MRI before robotic prostatectomy in order to improve the surgical procedure. They randomized 216 patients in the control group with no preoperative MRI, and 222 patients with an initial MRI prior to the surgery. So the overall positive surgical margin rates were not significantly different between the two groups. Only in the clinical T1C group, the use of preoperative MRI did decrease the positive margin rate significantly. And this is potentially due by limiting an aggressive nerve sparing procedure to only patients with no visible tumor close to the nerve bundles. That would be one of the interests of this initial staging before surgery. For the lymph node staging, the lymphatic involvement by prostate cancer is important as it may change the initial management from a local treatment to a more local regional or combined treatment. However, the two imaging modalities used for this purpose have poor sensitivity, 0.42 for the CT scan, 0.39 for MRI, but with a fair specificity in the 80 for the two modalities. And this also is a meta-analysis from University of Maastricht. The aspect and the size of the lymph node make it suspicious of metastasis when its diameter is over 10 millimeter and its shape is oval. When its shape is oval, but only 8 millimeter when it's a round shape and in the short axis. However, the nodal involvement is correlated with enlargement in less than 50% of the cases. So basically, the size itself doesn't mean that the lymph node is abnormal or is normal. Also, a high signal within the central parts of the lymph node on T2 images may indicate necrosis that would be suspicious of cancer growth. So they are the usual aspect of the suspicion of suspicious node on the CT scan. The MRI, this is a study from Germany, from München, and they use the diffusion-weighted images from the MRI to study and to better characterize the pelvic lymph node status. And this is an example, as you see here, on the T2 weighted image, you see a lymph node at the external iliac vessels here, which is less than 1 centimeter. That shouldn't be in the suspicious, but still visible, 0.9 millimeter in this case. And being enlightened here on the diffusion weighted images make this node very suspicious. And actually it was positive, and that was confirmed by histopathology after surgery. So they use this DWY, so this diffusion weighted images MRI, to optimize the diagnosis of lymph node involvement, and these are the results, where you see a significantly better area under the curve for the addition of DWY and ADC value compared to the only side of the node on the MRI, and this one was significant. Also, between the two, the diffusion weighted and the side, the sensitivity was almost equivalent between the two, but the ADC value was significantly more specific than the nodal side, and that was 85% for the ADC value versus 54% for the size of the node. The diagnosis of bone scan in newly diagnosed and treated prostate cancer use the bone scan, and it occurs mainly when the PSA is high in these patients, and even when the PSA is over 20 nanogram per ml. This is an old study from the Mayo Clinic published in 1993, and showing that basically the bone scan will be abnormal only for high PSA value, and in this study, the rate of false negative results for PSA got of less than 20 nanogram per ml was very low, less than 2%. So basically, the bone scan was positive only in very high PSA. The main deficiency of the bone scan is its relative low specificity. The uptake of the technetium, the radio tracer, is not tumor specific. It is difficult to distinguish between metastasis and some pathological condition, the trauma, the degenerative changes, the infection, and that results in false positive bone scan. The addition of bone SPECT to planar acquisitions improve significantly the sensitivity as well as the specificity of bone scan, and that's almost equal to the other techniques, the tomography-based techniques such as the MRI and the CT scan. So by adding a SPECT CT to your bone scan, improve significantly the results. Sodium fluoride, PET-CT, is very interesting. It's a highly sensitive method in the evaluation of bone metastasis from prostate cancer, but it has one problematic specificity, mainly because tracer accumulation also in non-cancer areas, in degenerative and inflammatory bone disease. So it's very sensitive, but poor specificity. These are results comparing the sodium fluoride to the new molecular imaging using the choline. So the literature provides evidence for superior detection of bone metastases by both the fluoride PET and the choline PET compared to the conventional bone scan using the technetium. So you have here on the patient basis the sensitivity of the fluoride, PET fluoride, so almost 87%. But a lower specificity around the 80. And that's for the choline. So choline is a precursor of the phospholipids integrated into the cell membrane during the cell proliferation. And basically, when you label choline with positron emitters like carbon 11 or fluoride 18, you can use it as a PET radio tracer. And that's a very good indicator for prostate cancer evaluation of cancer deposits. So so we will discuss, and Fred will discuss the choline PET at the end of the presentation. But again, in this meta-analysis, you can see that and it's already from a few years ago, show that the sensitivity of the PET choline is almost equal to the fluoride, but the difference is really on the specificity of this image. So moving on the next chapter, we will do an overview of the restaging modalities after failure of local treatments. So biochemical failure is usually the first events that confirm a primary treatment failures, either by after radical prostatectomy or radiation therapy. So the role of imaging is to rule out early metastasis and to detect a local recurrence, and eventually help to choose an optimal salvage treatment option. The definition of biochemical relapse after surgery, after radical prostatectomy, is, as you know, 2 consecutive PSA rises over 0.2 nanogram per ml. We know that when the PSA rise more than a year after surgery with a low PSA doubling time, the cancer recurrence may still be within the pelvic area. But however, only 10 to 30% of biochemical relapse are pelvic-only recurrences, and the majority of the cases present with occult distant metastasis. And the challenge is to try to find this distant metastasis. Salvage radiation is a standard treatment for biochemical relapse with no proof of metastasis after radical prostatectomy. Ideally, you perform when the PSA is still low, rising less than 2 nanogram per ml. Local cancer recurrences are mainly in the retrovesical area, the perianastomotic, and the seminal vesical areas after surgery. They are detectable by MRI in less than a quarter of the cases, and this MRI detection increases when the PSA rises. So multiparametric MRI is the most efficient conventional imaging for local cancer relapse detection after the surgery. So this is a study, a couple of studies showing that diffusion-weighted images using a high technique like a 3 Tesla machine, MRI machine, has a detection sensitivity of this relapse of 71%. But there is no added value of the T2 and even the DC sequences for the very small lesions. Most importantly, and that's probably the key message here, the optimal local recurrence detection is really obtained by using the combination of DC and T2 weighted images, and with, as you see in the combined different publications, a very high sensitivity and specificity. After radiation, the biochemical relapse is defined by the Phoenix criteria, a PSA rise by 2 nanograms per ml or more above the nadir. It occurs in approximately 30 to 50% of the patients within 5 years of treatment. Micrometastasis is present in 60 to 80% of the cases. Again, in this case, multiparametric MRI is particularly useful in the detection of local recurrence, but the T2 weighted images are very limited after radiation due to the post-radiation effects on the prostate. So that includes the gland shrinkage, the loss of the normal prostatic anatomy, the zonal anatomy, and also the decrease of contrast between the cancer spot and the normal prostatic tissue. And this is due by the effect of radiation, the glandular atrophy, and the fibrosis. So T2 is very bad imaging for after radiation. So the addition of diffusion-weighted images improves significantly the detection rates of this recurrence after radiation within the prostate. And basically the ideal is to combine the 3 MRI sequences, the T2, DC, and DW, and this is where you've got a very, very high sensitivity in this particular study, but also in this one. And also it's also different between the readers. Readers are more experienced than others, but the diffusion-weighted image is the key for this. So to summarize, multiparametric MRI is the optimal imaging modality to detect local recurrence after primary treatments. particularly the DCE, dynamic contrast enhanced sequence after surgery, and the diffusion weighted sequence after radiotherapy. So Dr. Pouliot will now take the presentation over to discuss the metastatic workup in these patients. Thank you, Fred.
Thank you, Frank. I will take over Dr. Bladou's presentation at a later stage of prostate cancer disease and look at the role of conventional imaging in that disease state. So let's just now upload my first slide. So one of the main questions once the patient fails to local therapy, either radiation therapy or radical prostatectomy and salvage therapies, is at which PSA we should image this patient to detect bone metastasis, which usually might indicate further treatments. So there has been a very interesting study that have been published by a group from Johns Hopkins University. In fact, they looked at the patients that failed the local regional therapies after radical prostatectomy. And these patients underwent a regular bone scan without any hormonal deprivation therapy. And they looked at the conversion from their bone scan from non-metastatic to bone metastatic prostate cancer patient. And interestingly, the median PSA after radical prostatectomy failure at which the bone scan converted to positive disease was 31. But even more interestingly, a quarter of these patients converted to positive bone scan with a PSA below 10. So I think that these results clearly show that some patients will have very early on metastasis. And those have been identified as those that have a very low PSA at diagnostic, those that have a higher Gleason score, and the patient that will have an early failure in the bone, so shorter time to metastasis. So in 2014, regarding the reimaging of patients that failed to local regional therapy, there have been a group of experts that have raised some recommendation in these patients. They recommended, based on these results, that the first scan should be done when the PSA reaches 5 or 10. And then if the imaging is negative at that point, we should repeat a second scanning when the PSA reaches 20, and then every doubling PSA time thereafter, based on PSA testing every 3 months. So once the patient has been diagnosed as metastatic and is under androgen deprivation therapy, one of the questions we could raise is there any role for repeated imaging during the follow-up? And the answer is no. The PSA is very reliable at that stage of disease, and PSA alone is sufficient to follow up the patient. And this has been confirmed by the new EAU guidelines that have stated that there is no role to repeat imaging at that stage of the disease. However, this is different for castration-resistant prostate cancer. There is two important aspects of imaging in that state of disease. First, trying to diagnose a metastasis might open the patient to life-prolonging agents, and it can also open the patients to bone-targeting agents, indications, and access to therapy due to reimbursement. The second aspect where it's important to use imaging is to follow the patient upon progression. The CUA guidelines regarding imaging in CRPC have recommended that patients with newly diagnosed CRPC be imaged by bone scan, a CT of the abdomen and pelvis, and a chest X-ray or a chest CT scan. If there is any contraindication to CT scan, MRI can be ordered, or if there is a lesion that is equivocal on CT or on bone scintigraphy for bone metastasis, MRI is more specific to diagnose metastasis and can be used. When you diagnose a metastatic prostate cancer that is resistant to castration resistance, you can find, in fact, metastasis in almost all body compartment. You can find bone-only disease in 40%, lymph node only in 10%, and you can find also soft tissue in about 5%. So the key points here is that if you only repeat the bone scan to diagnose a patient with a CRPC to find metastasis, you will miss a high number of metastasis. Last year, there was a very interesting paper looking at the conversion of M0 to M1 disease in CRPC patients. They looked at patients that had PSA, a biochemical recurrence, the diagnostic of a CRPC that were M0 initially at staging and that had repeated bone scan and a CT of the abdomen and pelvis. And they looked at the location of conversion. And interestingly, they found that soft tissue only metastasis occurred in about 30% of patients. Again, very important to image the visceral metastasis appearance and the lymph node metastasis because you might miss a third of patients progressing in these compartments. The same group also published last year a very interesting paper looking at the PSA level at which CRPC patients would convert from M0 to M1. And when you look at this, you can see that the bone positivity of bone scintigraphy occurred at a much lower level than at initial staging, as Frank presented earlier. In fact, when you look at patients that had a PSA below 5, about 5% of these patients have bone positivity on bone scan, and you can add another 18% when the PSA is between 5 and 14. So below 15, about 22-25% of the patients have already bone metastasis. So that indicates early on imaging with conventional imaging. Another aspect of PSA that could be used to predict the positivity on bone scan is the doubling time. The smaller the doubling time is, the higher the yield of having a positive bone scan has been shown in that study. And in the same paper, they have combined the two different parameters, PSA as a raw value and the PSA doubling time, to estimate when you combine the two what is the yield of getting bone metastasis on bone scan. For instance, if you have a PSA between 5 and 14 and a doubling time between 3 and 9 months, you will have a chance of finding metastasis of bone metastasis of 26%. So the same radar group that published recommendation for biochemical recurrent prostate cancer patients raised some recommendation for M0 castrate-resistant patient imaging. So they recommended that the first scan has to be done when PSA level reaches about 2. And then a second imaging, if the first one was negative, should be performed around a PSA of 5. And then every doubling time thereafter to find metastasis. So this is a very much lower level than at initial diagnostic because the yields are better and it can change completely the management. So what about now conventional imaging to follow the patient that are already metastatic under treatment and castration resistant? The definition of a castration resistant disease is a disease that progressed despite castrated level of testosterone, as you all know. The biochemical progression is a 25% increase of PSA at a PSA level of above 2, and confirmed by a second value 3 weeks after the first rise in PSA. The radiographic progression involves the progression or appearance of 2 bone lesions on both scan, or a progression of soft tissue using the RECIST criteria. However, something that is very important to be aware of is when you change treatment, you have to be aware of the flare phenomena that can happen on bone scans. In fact, in a proportion of patients, some metastasis might appear on bone scan, and these are due not to the progression of disease, but due to treatment change and bone remodeling due to the response of treatment that might cause osteoblastic lesions and uptake of the technetium in that area. So that might lead to false progression. So there are definitions for radiological progression on the bone scan after treatment change. Not only a patient after a treatment change has to have new lesions on the first bone scan, but you have to confirm the appearance of 2 other new lesions on reimaging after 6 weeks to avoid this flare phenomena and misinterpret these new metastases as progression of disease. In other words, if your patient is doing well, if there's a nice response, PSA, and a progression of bone scan, think about the flare phenomena and just reimage your patient a couple of weeks afterwards. So we talked about PSA as being a reliable way to monitor patients that are castration sensitive. The next step is to question, how should we follow our patients that are castration resistant and metastatic under treatment? And there is more and more evidence that PSA is much less reliable than earlier in the disease evolution. The paper published by the Prostate Cancer Working Group 2 already described this phenomena. When they looked at some studies, they reported that about 10% of patients had radiographic-only progression without any PSA, but that was not a dedicated study that looked specifically at that. Recently, this year, a study looking at the number of patients that had radiographic progression without any rise in PSA has been published. They looked at the database of the PREVAIL study to come with exact number of patients that have a rise in that did not have a rise in PSA and had radiographic progression. Just as a remember, you all know that the PREVAIL study compared before chemotherapy enzalutamide with placebo, and they looked at the overall survival, radiographic progression-free survival, PSA progression, and many other factors. And they reported an increase in overall survival in the enzalutamide group. They also showed a longer time to PSA progression and a longer time to radiographic progression. But the question here was, would PSA progression predict in every patient radiographic progression, and can we rely on PSA only to predict which patient should be imaged or not? So in this paper, what they have done, they have took only the enzalutamide treated group, and they looked at those that had radiographic progression. And in those that had radiographic progression, they looked at those that had a non-rising PSA at the time of radiographic progression. There were 65 patients compared to those that had a rising PSA and a radiographic progression. And basically, the characteristics of all patients were similar. And even more interestingly, you can see that the patient that did not have a rising PSA had a PSA detectable and a high level of PSA at the time of diagnosis. So it's not just low PSA secretor, it's cancers that secrete PSA, but will progress radiographically in other ways than by secreting PSA. So what they found, and what is very interesting, is that a quarter of patients, 24.5% of the patients, did progress only on radiographic progression without any PSA progression, which is really new and very stresses the importance to image this patient. Another question that they raised was, if your patient has a bone-only metastasis initially, once they're diagnosed, will they progress only on the bone, or they can progress on soft tissue? And in both the non-rising and rising PSA group, they found that about 40% of patients will progress in another compartment than their diagnosis. For instance, this group of patients were diagnosed in the bone initially, and they progressed in the soft tissue. So this, again, raised the importance to follow our patient, our CRPC patient, both with a CT scan and a bone scan at the same moment. So when to image a patient that has a metastatic CRPC patient? It is recommended to image them with a CT of the chest and abdomen and a bone scintigraphy at least every 6 months and before any change in therapy. This is supported by the new AUA guidelines that state that PSA alone is not reliable enough to monitor the disease activity in advanced CRPC. And also in 2015, there was an expert in CRPC consensus called the St. Gallen's, and there was clear consensus that patients should be not only monitored with PSA, but with repeated imaging with bone scan and CT scans to ensure that there's no radiographic-only progression at that disease state. So in summary, just regarding the role of conventional imaging in advanced prostate cancer, it becomes clear that the PSA is very reliable in hormone-sensitive prostate cancer, and we don't need to image this patient. However, we need to use conventional imaging, maybe molecular imaging, to restage prostate cancer early on to give access to a life-prolonging agent and bone-targeted therapies. And we need also to use these modalities to assess progression, and there is 25% of these patients that will progress only radiographically. So what about the new imaging modalities that are offered right now? I will just talk briefly about them and present them briefly. So molecular imaging in cancer exploits the ability of some molecules, they can be antibodies or other chemicals, to be used as tracer to image a specific process within cancer cells. And usually these tracers are labeled to an isotope that will be imageable by either PET scan or SPECT. As you can see here, the PET scan can detect a very specific uptake within a certain region of the pelvis. And when you fuse it to anatomical imaging, you can see that it's uptaken within a lymph node, showing the high sensitivity for lymph node metastasis, as opposed to this uptake here that is associated with bowel, which is non-specific. So the most utilized molecular imaging technique in cancer is probably the FDG PET, because FDG is preferentially utilized in aggressive cancer. However, in prostate cancer, there is no role, as you know, for FDG PET because there is no Warburg effect, at least in localized prostate cancer, and there is poor intake. So that has led to the development of some new tracer based on choline metabolism. Choline is the precursor of phosphatidylcholine, the most abundant phospholipid of cell membrane. It has been shown that choline uptake and transport and kinase activity has been increased in tumor cells. And especially in prostate cancer, where DG is not sensitive, three tracers have been developed. One of them is labeled to 11-carbon, which is FDA approved. This is 11-carbon choline. The half-life of this tracer is only 20 minutes, and this is why this tracer needs an on-site cyclochrome to be used. So every time a patient has to be imaged, you need to do a new batch of 11-carbon choline. The two other tracers are fluorinated, so the half-life of 18-fluor is much longer, 2 hours. So that allows a broader use of these tracers that are used in many sites in the world. And in Canada, to my knowledge, all the sites that use choline in the research use fluorinated choline because of the long half-life. Regarding now the accuracy of choline to detect lymph node metastasis before radical prostatectomy, there have been a meta-analysis that have compared 10 studies and 400 patients that have shown that this modality is more sensitive than CT scan with a sensitivity of 49% and a specificity of 95%. So another comer in the molecular imaging environment of prostate cancer are the new PSMA binder that can bind to the PSMA transmembrane protein. So the PSMA is a very interesting target for prostate cancer imaging because it's expressed in almost all prostate cancer, increased with disease grade. It is expressed also in prostate cancer metastases. And a lot of PSMA binders with good biodistribution have been developed in the last years. Currently, these are under a phase 2 and 3 clinical trial, and they can be labeled with either gallium-68, technetium, or fluoride. And much less studies have been published using PSMA binders because they're pretty new, but there has been already a meta-analysis looking at the sensitivity and specificity of PSMA binders imaged by a PET-CT. And this one here below has been published by a group of Western Ontario, where Glenn Ballman is one of the authors. And they have shown that the sensitivity of lymph node detection was 61%, while the specificity was 97%. So in terms of accuracy, it seems that the choline is better than CT, and PSMA imaging for prostate cancer, at least for initial staging, is better than choline in terms of sensitivity and specificity. So in summary, if we summarize the presentation today, I think that the conventional imaging indication for operative staging are well known by most people. The main indication is high-risk cancer. They are poor accuracy for CT or MRI for lymph node dissection, and also poor sensitivity for bone scan for bone mets detection at diagnosis. We have also discussed that PET choline is better than CT alone for lymph node and bone metastasis, with higher specificity and sensitivity, and the accuracy of the choline PET for lymph node metastasis is about 80%. It has also the advantage over other imaging modalities to image bone metastasis as well. The PSMA binders that I just presented are slightly better than choline PET for imaging primary staging, and now there's a lot of different PSMA tracers that are in clinical validation, and it will be important to see each of them, what is their role in the clinical management of prostate cancer. As Frank presented earlier, sodium fluoride PET-CT is more accurate than bone scintigraphy. It images, however, bone turnover, not tumor, and it is associated with approximately 20% false positive. So it's not that specific as are PSMA and choline tracers. Regarding, again, conventional imaging, in the castration-sensitive prostate cancer state, we recommend when there is a rising PSA after local regional disease to image when the PSA is between 5 and 10, and then after every doubling time. And there is no role for imaging during the follow-up in a patient under androgen deprivation therapy with stable or controlled PSA, because PSA is reliable. However, this is completely different in the castration-resistant prostate cancer. We have to look for M0 to M1 conversion early in the disease, and the conversion of bone scintigraphy occurs much at lower PSA than in a castration-sensitive prostate cancer state. And finally, in the metastatic castration-resistant prostate cancer state of disease, we need to image regularly a patient to look for progression, since about 25% of patients will show radiographic-only progression. And we have also to be aware that when we do a change in treatment in CRPC patients, if there is an increase in bone metastasis after 3 months, we have to repeat imaging and be aware of the flare phenomenon. So I thank you for your attention, and I think we have still some time for questions if there is. Thank you.